colleagues, सबसे पहले तो उनका शुक्रिया जो सुनने के लिए बैठे हुए हैं। मैं कहता हूँ मॉर्निंग में तो एवरीबॉडी इज़ फ्रेश, लेटर हाफ द डे इट्स वेरी डिफ़िकल्ट। बहुत बड़ा जहाद है लेक्चर सुनना। कुछ सुनाने वाला तो बेचारा लेक्चर तैयार करके वो तो लाइक स्पीड बोलता जाएगा, लेकिन जो जागते रहे और सुनते रहे उनकी बड़ा क्रेडिट है। And I was very amazed to listen that everybody is contributing 2,000 rupees per month to participate and get the registration and attend these seminars. I think those who are participating, they should be paid for that. क्योंकि बाकी जगहों पर तो पैसे दे के ऑडियंस लानी पड़ती है, ये वाहद ऑडियंस जहाँ माशाल्लाह पैसे दे के साथ आ रहे हैं. It's very encouraging, and I think our scenario and platform and awareness and all that is increasing and improving on the very positive side. जैसे भी डॉक्टर कलीम साहब कह रहे थे, वी आर नॉट दोज फैमिली फिजिशियंस विच 20 years बैक कि वहीं बैठे हुए हैं. माशाल्लाह नाउ वी विल इंटरेक्ट विद दीज आवर कोलीग्स, वी फाइंड एवरीबॉडी इज अपडेटिंग एंड दैट्स द वे टू go and compete with the international community. The topic which I am going to discuss with you, क्योंकि आपने मेरे लेक्चर ज़्यादातर अल्ट्रासाउंड के वाले सुने में शायद आप बोर हो कि ये कैसा लेक्चर है, बट आई ट्राई टू गिव यू द different brief idea about the imaging of the bones with reference to the long bones and the joint spaces as I've been asked to present, and what are the modalities which are available which can be helpful, and how you can make the diagnosis at your clinics in the minimum possible facilities available. Just to go through the normal anatomy of the limbs. The long bones, they do have the epiphysis, which is very, very important for the growing child up to the age of 17 or 18 when it becomes completely fused and then there is no bone formation growth on it. So the entire growth of the bone is taking place at these epiphysis ends. The next is the metaphysis, and the third one is the long shaft of the bone, is known as diaphysis. When we discuss the pathology and discuss the significance of each epiphysis, metaphysis, diaphysis, the peripheral outline which you see on the X-ray, which is comparatively dense line, that is the cortex, and central lucency, which you can appreciate, that is the medulla of the bone, which is basically cancerous bone over there. Similarly, one of the spines, if you look at this, the most important X-ray of the spine from the practice point of view, if there is any history of trauma. So once you are suspecting any history of trauma or any history of pain in the neck, you most commonly ask for the lateral spine. We do ask for the APU as well to look for the intervertebral disc space, and especially for the pain in the shoulder or the arms with reference to the cervical rib. But once you are looking for the lateral view, very important point is the certain lines which have to be carefully read out. If you appreciate these lines in every X-ray as a routine habit, let me assure you can pick up most of the pathologies. Above all, the first of all is known as a prevertebral line. That is a prevertebral line. If you look at the X-ray, that is the soft tissue prevertebral. The significance of this is that at the level of the C2 level, the prevertebral space should be around 2 to 3 millimeter in the normal patients. The significance is for those small children who got the adenoids. In that case, this prevertebral space that is increased more than 3 millimeter. And the maximum prevertebral space should be encountered at the level of C6, C5 level, and this prevertebral space should be less than the vertebral height. That means if this is the vertebral height, say it's about 1.5 centimeter or 12 millimeter, whatever the height of the individual is, variable from the age, from the sex, from the physique, this space should not increase the vertebral height. If you appreciate this distance more than the height of this vertebra, again please you suspect something wrong, either because of some foreign body he has taken it, an history of trauma, an history of infections, an history of something wrong with the GIT as well. If somebody has taken something, fishbone or so, and that is involved the wall of it, the only thing which is appreciated will be increased space. Or if there is any tuberculous spine over there, the intervertebral disc space may be lost, but the more important sign will be the prevertebral space, which is increased. Decrease is not important because there is a trachea, which you see the lucid channel lying upstairs, and due to that And that soft tissue is basically because of the esophagus, which is collapsed and closed unless until you take the meal and you take the food. Only then it becomes wide open. But normally it should not be more than 1 vertebral height, and this should not be more than 2 millimeter. Anything more than 2 millimeter, please look for any soft tissue swelling over here if it's adenoid or tonsils. If it's hair, please detail history of the patient is very, very important. Age of the patient, sex of the patient, and history, clinical presentation. Sometimes even lab support is very important. Similarly, if you are suspecting some trauma over here, if the space may be normal because there is no infection, there is nothing hemorrhage over here, then look for these lines. Look at this is known as anterior longitudinal line that runs and just anterior to the vertebral bodies. They all should come in line. If you make the vertebrae connected together, there should not be any distortion or any disturbance or any wavy pattern. It should be on one line. Similarly, the second is posterior longitudinal line, just behind the vertebral body. That's the posterior longitudinal line. They all should meet. That is very important with reference to the trauma, and especially with reference to fracture of the spines of the pedicles. Then I'll show you some of the pathology how they look like. And third is articular pillars. Fourth is spinolaminar line, and finally spinous process. If you look at them all, that they all have to make beautiful curves, and that curve is known as the secondary curve, which is made at the time of about 4 to 6 months when the baby starts holding his neck, or 8 months when the baby starts holding it. That is known as the secondary curve. The primary curve is all forward, and that extension or the forward extension is seen after 4 to 6 months of age. Regarding the bones, please let me assure you, it is always the plain X-ray of the area of interest is still very, very important, irrespective of the modalities which I am going to show you later on. But plain X-ray is very, very important, and especially plain X-ray of high KV, that means penetrative view, is very important, especially when you're suspecting some tumors or any small subtle change in the soft tissues which may not be visualized on under penetrative view. So the best is do the high KV or high kilovolt or high penetrative views. That's the best way. When you're looking for any bone, just remember this ABCS. If you just remember this habit of making the view of this any of the X-rays of the long bones, look first of all alignment. Do you see the cortical outline? Is it all okay, or is there any break into that, or is there a zigzag pattern? That means there is fracture, or there is any tumor over there, permeative, or whatever the type is. Second thing is bone quality. That means the internal trabecular pattern, is it well preserved, or it is being eaten up, maybe because of some thalassemias or other growth, or maybe bone cyst. Medullary cavity, it is all smooth, gentle, well preserved. Cortical integrity and thickness, if it is thin on one side, always compare one side with the opposite side. If you look at this X-ray, this cortical thickness on this side and this cortical thickness, they should be symmetrical, equal on either side, because there are certain tumors, certain benign or malignant diseases or your inflammations, you will find one side of the cortical thickness reduced, but the other will preserve depending upon the area of predilection in that very disease entity. Finally, look at it for the cartilage. Is that well preserved? Normally the cartilages are comparatively less dense as compared to bone, because the cartilage, they allow the rays to pass through. And finally, the bone X-ray is not complete unless until look for the soft tissues. Soft tissue means the facial planes, the myofascial planes, and this is the long bones. And the significance of that is, if you find any disease in the bone with the irregularity of the alignment, the trabecular pattern is lost, and the soft tissue, from there you can pick up if it is inflammatory or it is neoplastic. There are certain entities which are very close to each other, maybe difference between the two, because if you find these soft tissue planes, if they are well preserved or they are just pushed away, but still you can appreciate, then maybe tumor. But in cases of inflammations or acute osteomyelitis, in that case, because of the edema and the massive production of the fluid, this facial plane is lost. So please, you have to be very careful. The soft tissues, is it normal, or is it showing any calcifications, is it showing any bone formation? Because certain tumors, they grow out and produce a new bone formation, like osteosarcoma. I'll show you, you'll find the densities, or there's encounter sarcomas, you can appreciate the soft tissues calcifications. So we have to appreciate the soft tissues. Are they normal, are they well preserved planes, or they're disturbed? Once you're looking for the pathology, please look for, is it monostotic or polyostotic? Is there only one or more than one? And that is, if it's single, it will be osteoma or osteosarcoma, depending upon the bone, as my previous speaker discussed with you, because these are tumors which are lying mostly in the close to the axial skeleton. If they are multiple, one of the possibility is rheumatoid arthritis, better child we don't see in our society, alhamdulillah, over here. Multiple myelomas, metastatic disease, one very, very important disease, rickets, but rickets is the one which you find is symmetrical display pathology on either side of midline, sickle cell anemia and hyperparathyroidism. One thing is very important, please, history of the patient is very, very important, and I always say best is if you correlate with the opposite side. If you're suspecting the pathology on one side of the lip and in the history of any disease entity, always take the opposite side and take the AP and the lateral view, and sometimes even the oblique views may be helpful to make the diagnosis complete. Number 2, symmetry of the lesions. Are they asymmetrical or are they symmetrical? If they are asymmetrical distribution, that again suggests metastatic disease or Paget disease or psoriasis. If they are symmetrical distribution, that is very characteristics for the metabolic, as I told you in the rickets, leukemias, osteoporosis, osteomalacia in adults, and hyperparathyroidism. They are always produced because they are basically metabolic disorders. They don't have any specific site, so they spread out through the blood, and they can involve either side with the same distribution. Once you are looking for a bone, please look for the pathology, the position in the bone. There are certain diseases which are more predilection for the articular or subarticular space, metaphyseal pathology or diaphyseal pathology. Like giant cell tumor, everybody would like to look for the joints, short of joint, that is subarticular space. Similarly, site of the origin, location of the skeleton, is it the axial or the peripheral? Shape, is it rounded, it is well defined, it's smooth. Size, it is small or large. Margins, if they are very well defined margins, smooth margins, thin line demarcation between, that goes in favor of benign. Cortical effect over there, is the cortex of the bone is effaced, is it displaced, it is destroyed, it is permeative lesion, it is going to soft tissue now. Behavior, one of the very important requirement is serial x-rays. If you see a patient today and by chance you got a previous x-ray film of the same area, please do ask for the previous films, because that's going to tell you the aggressiveness of the disease. Is it slowly growing or it's aggressively growing? If a disease in the previous x-ray was a small lesion and a span of 3 to 4 weeks, the signs symptoms are getting worse and the size of the mass of the pathology is getting worse, that indicates the aggressiveness of the tumor. Is it benign or is it malignant? Appearance of the matrix and effect of the periosteum, is it lifted up or not lifted up? Clinical data, as I discussed, one of these is very important. Articular effects of it. Infection normally invades the joint spaces. Most tumors do not destroy the articular cortices or the cross joints. That's one of, very rarely you can see the osteoclastoma or the giant cell tumor. They normally don't, but sometimes they're very aggressive. They do involve this. Non-uniform loss of joint space is most common, indicative of DJD or the degenerative joint artery disease or the traumas. Uniform loss of joint space is suggestive of some inflammatory disease, osteomyelitis. Note the soft tissue changes. These are possibilities which you can look for: myofascial planes, fat pads, skin lines, masses, and alteration density. Is there increased density? Is there calcification? Is there new bone formation? You can all appreciate the soft tissues. X-ray of the area of interest is one examination, but sometimes you have to have other modalities and other techniques to finalize the pathology, and that is number 1, you can do the contrast examination like arthrography, angiography, lymphangiography, myelography, discography, depending upon the area of interest and the most appropriate investigation which is required to diagnose that. Similarly, radionuclide imaging, as partly discussed, it's very, very important. Immediately, some books say that after the X-ray, if you know the history, go for the radionuclide study. The basic aim behind is if it is monostatic or polystatic, this is the best modality to know if this lesion is limited to this area which you are looking for the X-ray, or is it going to other areas as well. And the best answer is done by the radionuclide studies. We'll discuss if we get time at the end about the details about the radionuclide images. It's highly sensitive, but at places you can't differentiate between the primary or the secondary or metastatic inflammatory diseases, but history of the patient, age of the patient, and then the findings, they can help you quick diagnosis for multiple areas to be involved in that case. Ultrasound. For any of the musculoskeletal, I have attended about 3 of the international workshops regarding the ultrasound. Once you listen to the workshop of ultrasound, they say it is much more discreet and much parallel to the MRI these days, especially for the joints, for the peripheral areas, and not the deeper down. But if there's any area which you want to do it, there was a conference where we were just studying these early signs of rheumatoid arthritis. The X-ray takes about 6 months to appear on the early signs of rheumatism. But the ultrasound, the synovial thickness, but these days we are doing even the biopsy of the synovium to early diagnose pathology. But I think the idea of all these modalities is to complement each other, to support each other. There are certain areas which you can find the difficulty, but you can always take the help of this modality. So ultrasound better underutilized, but let me tell you, it's far help. I'll just show you a couple of the slides on the way. Similar tomography, but these days tomography is replaced by CT, which has got 10 times more helpful than the X-ray, and still better, let me tell you, for any of the musculoskeletal pathology, MRI is very helpful. But the only difference where I say ultrasound MRI, but if you compare the two, number one, ultrasound is very much operator dependent. If I don't know, I'm totally making the blunders, but if I know it, then I can do the job. The second help of the ultrasound as compared to MRI is, if there's problem on the right shoulder joint, you can do the right shoulder joint, but if you've got any suspicion of pathology over there, you can just put the probe on the opposite side and you can always compare. The comparison is very quick, very safe, and there's no radiation involvement. It is no cost effective, very much cost effective that way treatment. But for any of the musculoskeletal areas, MRI is very helpful. Finally, for any tissue diagnosis, sometimes you may not be able to reach it, you can take the biopsy, and that is the best way to confirm the pathology, especially in the tumors, and to know the cell origin of the tumor, you need the biopsy. CT in traumatic lesions, pathology or anomalies, they are well demonstrated in areas of complex anatomy that are difficult to display on the plain film. That is the area in plain X-ray of the hand or the wrist joint, you may not be able to need the CT unless until you suspect the tumors, and to know the aggressiveness of the tumor and involve the soft tissue, then you may need it. But especially in the skull bones, the facial bones, the spine, the pelvis, where the complex bones, multiple bones are there, and small subtle lesions with associated pathology in the adjacent areas, CT is more helpful. CT shows soft tissue contrast 10 times. In routine X-ray, you can appreciate 3-4 gray scales like gas, like bones, like muscles. But if you do the CT scan, there are plus 1000 and minus 1000, so many gray shades you appreciate. The normal muscles or pathological muscles, muscles with hematoma, muscles with abscess, muscles with tumor, the same muscle on X-ray will look only simple gray. But in the CT scan, it can differentiate exactly how the first muscle planes are. Is it containing any debris? It is containing hemorrhage, because the density can verify right on the spot while you're doing the CT scan. Similarly, ocular fractures and bone fragment locations, intra-articular fractures, they are shown better on the CT scan. CT is a modality of choice for calcified soft tissue lesions, hematomas, myositis, ossificans. Finally, the MRI, it provides optimal visualization of spatial relationship and distinct soft tissue contrast to view the intervertebral disc space. 100% is very, very gold standard, state of the art. Spinal cord and meninges, nothing can be helpful than this MRI. Much, much better than CT or anything else. Bone marrow, perivertebral soft tissues. For any of the soft tissues, is very helpful. Let me tell you, for any patient who has suspected case of CVA, the first CT finding will be observed after 12-24 hours. But MRI can tell you if there is no clinical signs symptoms, but you are suspecting the patient having CVA, the earliest signs on brain MRI can be very less than 6 hours. So if you go for MRI in the first 6 hours, the idea behind that is to start the streptokinase. Do you think he needs streptokinase? Normally do the CT of the brain. If there is no hemorrhage, we can start it. But if you are suspecting any small lesion, the best is, if you can afford it financially, one should go for MRI, because the lesion can pick it up in less than 6 hours. So same is here, and the main advantage is there is no radiation hazards. The only hazard is if there are some metallic parts on your body, and sometimes patient with a phobia because lie down the tunnel. But these days, open MRIs, they are available. How the dissection of the bone, once you're looking for, how it looks like geographical, sclerotic. Please let me show you one thing. If you find any area which is lytic, with a very thin zone of demarcation between the normal bone and the abnormal bone, if it is thick sclerotic margin and a thin line between normal and the abnormal bone, that is very much diagnostic of a benign lesion. But if you find a wide zone of transition between the normal and the pathological bone, as this distance is increasing, this wide zone of demarcation, that again indicates a malignant disease. Similarly, mouth eaten and permeative. This is basically seen in some kinds of aggressive tumors like Ewing sarcoma or osteosarcoma. I'll show you, if they destroy the cortex and go outside, that is permeative lesions. Similarly, sometimes there's bone reparative process going on. There are different presentations, like here and on we'll see in cases of thalassemia. In certain cases like osteosarcoma and Ewing tumors, we can see the Codman triangles and lamination in Ewing's tumor. Again, tissue characterization is it basically bone is formed of two things. One is the osteoid, which is a basic component, and bone is that is soft bone. The bone is not complete unless until this is calcified, and this calcification or all this calcium, that deposition makes the bone stiff. If there is only growth of the osteoid, that it presents a lucent area. But if there is more of the chondroid formation of the calcifications, that gives dense area in that area. Now I'll just show you how the different areas, fractures I'll just run through because my colleague has very nicely elaborated. I'll just show you a couple of the fractures over here. As first of all, I'll just show you how the subluxations look like. There's normal X-ray as I discussed a couple of minutes back. You can see the prevertebral space, you can see the anterior, posterior spinal lines, and that's pathology. Can you ask for the light? थोड़ी कम हो सकती है? ये दो lights off हो जाएं. Localize the kyphotic angulation. If you look at this, as we show you normal, you can see one line here. If you look at this X-ray, there you can appreciate the normal lines coming up here, normal lines here, but this is not coming in continuity with this line. The next vertebra, C6, which is much posterior. The question is the sixth one is displaced or the fifth one is displaced? Normally it is the one which is more fixed. This is not displaced, it's basically this one displaced. So C5 is displaced anteriorly over the C6. If you look at the lines, this line is pretty good over here, but then there's a break in the line. That's the one which is the C6 level, and that's C5 level, which is protruding anteriorly. So that means fracture of at the level of the posterior elements of the C5. With the result, it is posterior anteriorly. While we are doing the X-ray, the more important thing is please go for the MRI. The purpose of MRI, look at this brain tissue, look at the spinal cord. The message is not only to see this fracture because that managed. The important thing for the surgeon and the orthopedic surgeon is how far the effects of this. Is the patient going to get quadriplegia or not? Look at the spinal cord and look at the level it's being pushed. So this spinal cord is pushed anteriorly. That means it's not only fracture or subluxation, it is causing impingement over the spinal cord, which needs to be corrected, and that's why the patient can survive better. Now just to show you a couple of fractures over here, fracture of the clavicle. If you look at this laterally, and there's a fracture line over here, the lucent line over there. Please, sometimes these things are seen in the form of metastatic disease as well. History of the patient is very, very important. With a young man coming with history of trauma, cricket playing or boxing, anything, that's okay. But if you find incidental finding, please X-ray of both the clavicles and look for the primary. It will be simple osteolytic lesion or metastatic lesion on one clavicle over here and maybe the opposite side here. You look, sometimes the picture is the same. The distal end is totally eaten up in that case. Very common pathology which you come across is the dislocation of this shoulder joint. Look at the normal shoulder joint over here. That's a glenoid cavity, very nicely fixed over there. If you look at this, how to diagnose the different locations, anterior, inferior, posterior dislocations. I'll show you some of them. Look at the glenoid cavity. That is glenoid cavity, you can appreciate. That's the coracoid process, and that glenoid cavity is missing the head. The head has gone down because with this, there's a fracture, small fracture of the humeral head, you can appreciate here. And that is the humerus head is inferior and medial to the glenoid cavity. That's basically the glenoid cavity. Instead of lying here, it has gone down, and that's the one which is the most commonly encountered dislocation of the shoulder joint. Again, you can appreciate it. That is known as subcoracoid dislocation of the humeral head coming down and towards the medial side. Sometimes the rotator cuff tears these days with the high resolution, something like 15 megahertz or 14 megahertz, we are diagnosing these tears, especially in the sportsmen and young and even old ladies when the hands become rather restricted. To appreciate this, initially we used to do the X-ray, minor density at the level of the linear density at the level of supraspinatus muscle. But these days you can appreciate on T2 weighted, you can appreciate this image. There's a fluid, fluid is always white and dense, we call hyperdense on T2 images. On T1 weighted images, they always look black. So that's very, very important, is the T1 or T2 weighted images. And then you can appreciate the rotator cuff tear. That's lucency, you can appreciate it. That's the area where you can see this tear of the rotator cuff muscles. Again, you can appreciate this fluid. Normally don't appreciate the fluid over here. Then you can appreciate this. That's the bursa over there. Sometimes, that's very important, you can appreciate the glenoid cavity. It's here, the head is lying here, and the one lies with. Fracture, again history is very, very important. If a young man, short in onset, because of external movement, fine. But in old age, if with little trauma, the fracture over there, please look for the rest of the bone. Is this all bone well preserved? The cord is okay, the density, the trabecular plate is okay, because sometimes these may be pathological fractures. If there is metastatic disease over here or any disease over here, with the result, the disease may not be evident unless until there is a fracture. So a history of the patient is very much important. You can appreciate that. What do you appreciate here? The joint space is well preserved. Very lucent line, very thin lucent line, you can appreciate it. Supracondylar fracture. But the message over here is, once you find the fracture, the most important thing is there any displacement of the fragments or not? Here you can appreciate there is no displacement of the fracture. There may not be an aggressive surgery, but the orthopedic surgeon can answer better whether it simply needs follow-up and conservative management or does it need surgery. But the message behind this, you can appreciate this lucent line from one side, it has not gone to the opposite side. So fracture is there, maybe because of trivial trauma. Similarly, here you can appreciate this ulnar fracture here. I'll just run through the slides. That is another most common fracture, which you call the Cooley's fracture. The diagnostic sign is the distal segment goes posteriorly. When you do the lateral view, the distal segment goes posteriorly, and that is the impaction of it. Appreciate this line. There's a lucent line over there, and these are all the diagnostic signs you can appreciate over there. Comminuted impacted intertrochanter fracture. How to appreciate? For hip, please, I will just suggest one thing. When are you suspecting any old age patient for any history of minimal trauma, minimal fall, the first thing we look for is the fracture of the hip joint. Please, what my request is, advice is, get the X-ray of the whole pelvis, not the one hip joint where she is complaining of pain. If you get the whole of the pelvis, one big film by 14-17 inches, then you can compare this line. Here, the only positive finding, if you look at this carefully, this lucent line. The main purpose of asking for comparison film is, sometimes you may not be able to appreciate the subtle change, but you look at the opposite side, which is healthy and normal, you can appreciate the pathology over there. If you look at the greater trochanter, look at the lesser trochanter, and look at the lucent line in between the two dividing two, that's the comminuted fracture. And there's one segment over here as well. It's a comminuted intertrochanter fracture of the left hip joint, left neck of the femur. And that is tears. When I was last year in Germany, there was a conference of this musculoskeletal. Believe me, all these things were shown by the consultants on very high resolution ultrasound. And according to one of the speakers, just give me the ultrasound and give me the patient. Don't give me the MRI images. I'll give you the images as good as on MRI. But that is very high experience and a lot of knowledge about the ultrasound node. We are still lacking behind that. What is positive finding? You can say this is horizontal tear of the posterior horn. That is basically the one meniscus here. If you find this lucent line or hypointense area, there's the early signs of meniscus tear. There are 3 grades, 1, 2, 3, depending on the duration. If they are 1, they are minimal, 2, they are minimal. But if they persist over there, they go to grade 3. That's grade 3 meniscus tear over here. Again, you can appreciate here, meniscus tear, grade 3 you can find over here. Again, you can find it here. Just to give you the idea of how the multiple modalities can sometimes have. This is a young boy of about 18, 19 years who had no complaint. That's very interesting. Who had no complaints whatsoever. He was going normal. He was playing cricket. He just took a shot. And immediately after this cricket, he started complaining of pain in the right shoulder joint after he played the cricket. By the evening, when he came home, he was starting complaining of pain. Look at the glenoid cavity, that is well preserved. The clavicle is okay, there is no fracture. But the positive finding is very well defined, smooth outline without the break of the cortex in this X-ray. Now let's show you how the multiple modalities are helpful. On simple X-ray, you don't find any fracture here. Well-defined lucent area in the upper end of the humerus. That's all. And little density over here, you can appreciate it. But the cortex on this X-ray appears well preserved. So that was the incidental finding when the boy complained of this cyst. So we diagnosed as a simple bone cyst. We go ask for the CT scan. If you look at the CT scan, that is the upper end of the humerus. If you look at this area, there's one fracture here, there's one fracture here, and there's minimal malalignment of the bones. One bone is being pushed inside, and that is all cyst which you appreciate. Normally, the bone look like this. The internal medullary cavity should be looking like this. But look at this hypodense area, well-defined smooth outline, with 2 sites of small fractures over there, but no disalignment. On X-ray, we couldn't appreciate if there is a fracture or not, except lucent area. But still, he was complaining of pain. There is no displacement of the fragments, so normally not pain. Then we ask for the ultrasound. If you look at this, he was 17 years boy, very nicely outlined cortex of the shaft of the humerus. If you look at this carefully, one chip fracture here, one fracture here, and there is a fragment over there, which we saw on this CT scan. If you look at this CT scan, that is the one. If you look at the ultrasound, that is the area of the fracture over here and fracture over here. We did the second transverse view, and that is bone, and there's small chip fracture which is lying inside it, and that is the one which we see here. Then still he was complaining of pain. The color Doppler was carried out. If you look at this hypocac heterogeneous area, that was basically a hematoma which was causing pain to the patient. So the purpose of all these modalities, he was not given any surgical treatment, just otherwise bed rest and little support the joint, because once this hematoma is going to settle down, his pain is going to settle down. So but the purpose of multimodality image is to diagnose the things at an earlier so the management can be started. Next is how to look for the tumors. That's very important slide. Once you are suspecting it's a bone mass or a bone tumor, there are two questions come to your mind. Is it non-aggressive or means benign, or is it aggressive? If you just keep this slide in your mind when you're looking for the X-ray, you can reach to great extent to the diagnosis. First of all, well defined. Is the margin smooth, gentle? That means it is not aggressive. But if they are ill-defined, irregular margins, that shows aggressiveness of the mass. Sclerotic margin, that is very, very important. Sclerosis is basically a reparative response. That is a response of the host bone against any infection, any disease. If there is a tumor, the bone response is minimal. But if you find a response over there in the form of dense shadow in the periphery, that is a reparative response, and that indicates it's a benign disease and not a malignant disease. No sclerotic margin, no difference between the diseased and the normal bones. But if you find a dense line, I'll show you in the next slide, then you can appreciate it. Narrow zone of transition, as I show you, one of the diagrams, if the line is thin between the abnormal and the pathological bone, that indicates a benign nature. But if it's a wide zone of demarcation between normal and abnormal, that indicates a malignant nature or the aggressive nature. No periosteal reaction, occasionally thin laminated margin, very rare, normally not, as I show you one of the slides in the previous axis. But in aggressive tumors, there is periosteal action, laminated, Codman, sunburst appearance. All I'll just show you slides. How do they look like? In one of the diagrams, they make the ends triangle, Codman triangle because of lifting of the periosteum, or there may be sunburst appearing. All these findings are noted in cases of malignant or the aggressive tumors. Intact cortex, very important. If the cortex is intact, there is no involvement of the soft tissue, no break in the cortical outlines, that indicates it looks like a benign. But in aggressive tumors, there is a brain and extension of the surrounding soft tissues, muscles, or wherever the areas are coming in. How we proceed with the tumor if suspecting, pattern of destruction and pattern of repair. That's very important. Aggressive and non-aggressive. Non-aggressive location is very important. Central and cortical. If it is central, it may be simple bone cyst or may be enchondromas. I'll show slides. If it is cortical, there may be fibrous cortical defect or non-ossific fibroma or aneurysmal bone cyst. These are the benign pathologies which look like tumors, but they are benign tumor. But if you are suspecting this is aggressive, it may be matrix, it may be bony, or it may be cartilaginous. Don't know, one of the two. If it's osseous, there may be osteogenic tumors or a sequestrum in cases of, or if it's cartilage tumors, chondrogenic tumors, but predominantly they are having calcifications. And others, they are bone marrow tumors, fibrogenic tumors, and all varieties of tumors. From there you can assess it. Look at this one slide between the benign and the malignant growth. If you look at the spines, there is a well-defined, smooth outline, lucent area in the vertebral body. If you look at the lines, there is a dense line behind that again indicates circulatory process. That is a reparative process. That means it is not allowing this disease entity to grow aggressively. Demarcation between the normal and the abnormal bone, there is a very thin line of demarcation, and there is no break in this outline. On the contrary, if you look at this X-ray, there is a lower end of the femur, there is a knee joint, there is a patella over there. If you look at the cortex over there, the cortex is broken up. There is abnormal, irregular, heterogeneous, dense shadow with break of this cortex permeated disease easily. And look at the soft tissues, it's extending to soft tissues. They all look like bones, but basically these are not calcifications. There's a bone growth of the osteosarcoma kind of growth malformation. So between the two possibility diagnoses, if the X-ray is brought to you, you can simply say this looks like a benign and this looks like an aggressive tumor. Further investigations, depending on the age of the patient and presentation of the patient, and serial follow-up if they have the X-ray, or further modalities like MRI or whatever the modality is required, depending upon the presentation. If it is short in onset, it's different, it takes time. Younger age group, maybe 10-25, maybe osteosarcoma, because it looks like typically a case of osteosarcoma because they normally remain around the exoskeleton and the proximal distal end of the humerus or the proximal end of the tibia fibula. The same patient which I showed you last time here, I'm just giving you the look how it looks like. Look at the stitching. It's basically a case of osteoblastoma. What are the findings? Dense sclerotic bone reaction more than 2 centimeters. Look at this. Expansile, well circumscribed lesion in ABC, AMIS and rheumasis. That is one of the possibility. Variable cortical calcification matrix, don't find it here. Malignant aggressive osteoblastoma, these are the possibilities you can. Malignant aggressive osteoblastoma may disrupt the cortex very rarely. Has a soft tissue component which may be involving outside it. Like this you can appreciate here. If it grows outside the cortex as damaging it and soft tissue, that becomes the aggressive nature. If you limit to this one, this osteoblastoma which has not become aggressive and become malignant, it so far looks benign nature. Second, osteosarcoma you can appreciate, that is AP view. Always please in bone x-rays, always get 2 x-rays, because in one of the views only, AP view, you may miss the pathology. All the x-rays of the body are AP view except chest, and that is PA view. You can ask for skull x-ray, AP view, ask for any x-ray, but only chest is PA view, because basically in the chest x-ray our interest is to look for the lungs and the heart being more close to the cassette, we call the PA view, not the AP view. If you look at the AP view, the only finding is dense bone over here. Look at the time. But that's the beauty of this x-ray. If you do the lateral view, this indicates that varieties of osteosarcoma, it may be osteoblastic activity much more over there. Irregularity bone, but beauty is the joint space is well preserved over there. Osteoblastic means 50% they are known as osteoblastic activity. Osteoblastic means excessive osteoid bone formation activity. Chondrite about 25%, spindle cell carcinoma about 25%. Aggressive periosteal, all the findings you can see Corman triangle, sunburst appearing exactly opposite to the main cortex that growing upside. If you look at this osteosarcoma, I'll show you the x-rays and how the MRI T2 weighted images. If you look at the x-ray of this lower limb, this fibula, you can appreciate is this hyperdense irregular permeative lesion, because it's breaking the cortex and going to soft tissues. If you look at T2 weighted images, there are multiple areas spreading out in the form of spicules, the bone formations in the T2 weighted images and spreading into soft tissues. The basic purpose of this MRI is to know the compartments, how many compartments have involved and the aggressive nature, because the surgeon will require to know which compartment he is going to enter and how much surgery he needs that. Similarly, I'll show you enchondroma over here. Radiographic features, lytic lesion. Basically, they're all lytic lesions in the bones of the hand or the feet. Chondrite calcification, rings and arcs. If you look at this X-ray, that's the lucent area over here. The cortex is well preserved. If you look at this hand X-ray, one of the fingers, there's a lytic area, lucent area, well-defined, smooth outline, and there's no cortical break. Sometimes there may be break because of the trauma over there. If you appreciate here on CT scan, that's the femoral head which is well preserved. You look at this femoral head, there is a lucent area, but there's minimal cortical break, maybe because of trauma overriding this tumor over there. As I told you, normally these enchondromas, they don't show the fractures unless under the history of trauma to the patient. You find these multiple lucent areas, but somewhere you can appreciate this break, and that is the pathological fracture of the tumor over there. Ewing's tumor, that's very important in the younger age group, and especially because the presentation is the same. If the normally it starts from 5 years onwards, that you will encounter in a young boy if he's got painful leg, high grade temperature, ESR is raised. The difference is between Ewing sarcoma and osteomyelitis. That's very, very important, because the clinical presentation is same. We may be treating it like osteomyelitis, but it may turn out to be Ewing sarcoma. There are certain diagnostic points which can help out, but again the laboratory support, the MRI, all those modalities, and the formation of the growth. In the cases of osteomyelitis, there is formation of sequestrum, but in cases of Ewing sarcoma, you don't find these pathology. What are the possibilities here? Look at this lytic area over there. This is eccentric, and that is involved in this cortex. If you look at this multiple soft tissues, cortical, these calcifications or new bone formation, you can appreciate over here. The presentation is exactly the same: high grade temperature, pain lower, pain at the site of the complaint area. But if you look at the facial planes, they are pushed but they are not lost. If you look at this soft tissue shed over here, look at this soft tissue shed over here, that is preserved. In cases of acute osteomyelitis, the first thing is the bone change may not be so evident, but the first change is loss of soft tissue muscle planes because of the edema formation that gets lost. If you look at the MRI and look at this bone over there, there is heterogeneous hyperintense on T1 weighted contrast on imaging. You can see the growth. The bone is well preserved up beyond that and well preserved just above that. So that is the area which is evolving. At the same time, it is involving the distant soft tissue muscles over there. Similarly, giant cell tumor, this is a tumor of the adult age. Mature skeleton from 20 to 40 years of age, and the most common sites, they are the axial skeleton or the bones like the distal end of the femur. The diagnostic tip is they are eccentric, they are lucent, and they are subarticular. Normally they don't involve the joints. If you look at this sacrum, there is one large lytic area, expansile lytic area, but it has got the damage over here. Another is you can see the sacrum over here or there. You may appreciate the lower of the femur or upper tibia, but the diagnostic is normally they do not involve. It's always seen the mature skeleton, lytic subarticular. That is very, very diagnostic. They always remain below the joint scale. It is expansile and eccentric, not in the middle, on one side of the bone, and you may appreciate it. Narrow transition and no sclerotic margin. That is, as we discussed in the earlier differentiation between the malignant and benign, there is no sclerotic. If you appreciate it, there is no sclerotic margin, means there is no reparative response of the normal bone in that adjacent because highly malignant. Maybe locally aggressive, pathological fracture in 30% cases, and that is only seen when there is no overlying cortex over seen there. Little movement, little jerky movement can lead to the breakage, but basically it's a tumor over there which has led to the expansile nature, minimal cortical tissue, and minimal trauma can lead to damage of this normal cortical leftover bone tissue. Look at this hand of the patient, very nicely outlined the cortex, this centrotubercular pattern. If you look at this joint, beautifully preserved this joint and this joint. But what you appreciate here is all large expansile lytic area involved in the entire bone. Because of the excessive growth, it can go on to the soft tissues as well. Multiple myeloma, basically it is a disease of the old age. If it is one lesion, but predominantly when we see here, it is always multiple myeloma. And how it presents, that's very diagnostic. Multiple myeloma has two common appearances. Number one, multiple well-defined lytic lesions, and the diagnostic sign is punched out lesions. Very discrete, variable size, and most commonly we see this area, things in the ribs or in the skull. I'll show you one of the two slides. Generalized osteopenia with vertebral compression fracture. Fractures are not because of anything, because of the decreased bone matrix, because of decreased bone quality and the volume of it. The bones become very fragile, with the result they may fracture. Without any trauma, by simple doing your movements, the fracture of the old people, they break down. Plasmacytoma, if it is one lesion only, then tends to be large and expansile. MRI, replacement of the normal marrow, which is very, very sensitive diagnosed tool. Bone scan, it will be normal, cold or hot lesions may be appreciated. Skeletal survey, more sensitive than more scan, but still missing significant number of myeloma. Atypical findings rare. Complications, as I told you, in 20-30% patients, they will have pathological fractures. Amyloidosis, one of the complications. Most plasmacytomas progress to multiple. 90% by the time the patient comes to the clinic presentation for any complaints, if it's simply one muscle, one bone, it is plasmacytoma. By the time it is presented to the physicians, it is always spread to the other areas. The once it has involved more than one system, more than one organs, it's a case of multiple myeloma. If you look at this X-ray, you can find multiple small lucid areas punched out, very sharply defined, variable areas. If you look at this, look at the bone density here, look at the bone density here. There is ill-defined osteotic lesions with end-osteal scalping. If you look at this, look at the end-osteal scalping. Normally it should be as thick as this one going on. If you look at the hair, it's a thinning out and scalping of the cortex, but well preserved. Arthritis. There are varieties of arthritis, but we'll just show you two slides. One is rheumatoid arthritis, how it looks like, and what is the other senile changes, osteoarthritis. There are three types of arthritis which can often be distinguished radiologically. DJD or degenerative diseases, they'll show you multiple osteophyte formation, subchondral sclerosis, uneven loss of articular spaces. Number two, inflammatory arthritis, unmarginal druins, periarticular osteoporosis, soft tissue swelling, which is most common cases of rheumatoid arthritis, uniform loss of articular spaces, metabolic, lumpy, bumpy soft tissue swellings, and marginated bony erosions with overhanging edges. I'll just show you how the osteoarthritis changes are seen. Narrowing of the joint spaces, usually asymmetrical. That is very, very diagnostic, because when we discuss the rheumatoid arthritis, they are symmetrical, as we saw in one of the early slides. Subchondral sclerosis, that is again a cerebral response. The bone matrix is decreasing, but because of the response of the bone, there is sclerotic element going on there. Subchondral cyst, true cyst or pseudocyst, these cysts are basically because of the break of the articular surface. With the result, there is oozing of this synovial fluid into the areas, and that leads to the formation of the cysts. Lack of osteoporosis, that is very important sign. We don't find the osteoporotic changes here. While in case of rheumatoid arthritis, we'll find the osteoporotic changes because of disuse, because of painful, and the patient don't use the hands, and that leads to osteoporotic. But in osteoarthritic, you'll find the skeletal survey. If you do the survey, the bone will look normal, except these changes which we can appreciate. Joint space may be narrowed, especially in the spines. I'll show you here. Look at the joint space that is narrow on the medial side. Predominantly, these patients will show you the narrowing of the joint space on the medial side, not on the lateral side over here. Look at the joint space. And the diagnostic signs: number one, narrowing; number two, reparative response. Look at this density of the margins of the ends. They are getting more dense as compared to the rest of the bones, and that is the response of the bone into the narrowing of the disease entity. Number two, multiple osteophyte formation. Here you can see, here you can see here, multiple osteoformation and reparative response is suggestive of osteoarthritic changes. Rheumatoid arthritis, there are 6 signs which you are supposed to look for. The earliest signs will be the swelling. That is the first complaint, predominantly seen at 20 to 40 years age, and mostly the ladies. And the clinical presentation will, the lady will say in the early morning, especially summer, जब मैं उठती हूँ तो डॉक्टर साहब मेरे हाथ नहीं काम करते, जो धूप आती है तो मेरे हाथ ठीक हो जाते हैं. So by the time the lady gets up, they are because not used in the morning, so gradually they become very stiff and become painful. Over the time, with 2-3 hours, then they start moving some mobility. That is one of the earliest clinical presentation of such patients suspected of clinical arthritis. How you are going to see on the radiologically, the first thing on the X-ray of the hand is most common is metacarpopharyngeal joint. That is the first thing they are going to involve. And what is the positive finding on the X-ray? If you look at the whole of the X-ray, that hand will show the soft tissue swelling. Rheumatoid basically disease where you seronegative disease, and the first thing is there is excessive production of pannus formation and thickening of the synovial membrane. That thickening will lead to the widening of the joint space. That joint space is going to be widened out, and that because of the excessive secretion of the synovial fluid, the synovial membrane will be thickened out. The only positive finding on X-ray will be there is symmetrical fusiform swelling of the finger. That is the first sign. Gradually, there are 5-6 further signs which you can appreciate because of the increased amount of fluid over there. You can see this erosions over there. There are cracks going to be in this articular surface. Because of the cracks, there is a massive fluid over here. This fluid starts getting into it. So number one, it's going to cause erosions, which I'll show you. Second thing is this fluid starts going down, and these are going to produce a cyst formation. These are not the true cysts. These are cysts because of the oozing of this material into the joint space, like this we have produced over here. Similarly, there will be narrowing. Early distential joint space, then gradually the narrowing, and too much narrowing that you can't appreciate the joint space. These are the classical signs which are gradually coming to the lady over the span of time. I'll just show you. Look at the normal hand. That's the first place we're going to come out in the metacarpopharyngeal. These are the carpal bones, metacarpals and pharyngeal. That is the first stage you can look at this. And the diagnostic sign between the rheumatoid arthritis and the gout disease is this is subarticular and that is periarticular. That's very, very important. Look at the joint space where it is well preserved. If you look at the joint space in this area, that is getting narrowed. Look at the joint space getting narrowed, and that is periarticular osteopenia because of the disuse. Because the patient is painful, they can't do much of the work. With the result, the bone density decreases. One is localized osteoporosis, the other is generalized osteoporosis. The whole of the skeleton then becomes less dense as compared to the of lady of the same age. But that way you can see localized. Because the marginal erosions over the time, because once it goes down into it, the space gets narrow. First is soft tissue swelling, and the swelling is bilateral, symmetrical. We call that fusiform swelling. I'll show you one of the X-rays here. And sometimes you can see the subluxation of the joints, and sometimes there may be fractures over there, and the typical is bottonian deformity or swan neck deformity depending upon the area or the which is all. Sometimes, if the disease is more aggressive, you look at this ulnar process, that becomes totally averse, totally eroded over there. You can't appreciate that. And look at the joint space; they're becoming narrowed, and their deformities. Even I have seen the teachers who are school teachers basically, and those ladies should not be allowed to work as a school teacher because of the osteoporosis, because of rheumatoid. Once they ask the students write on the board, by doing these persistent movements, the scapula being a strong end doesn't get dissolved, but the posterior ribs which are coming in close contact with the scapula, they get eroded because of the persistent movements, and by the time, after maybe some time, the lady's posterior ends of the ribs will be completely eroded and they become totally dysfunctional. So such patients, once you do this survey and you find the bone density decrease, this kind of job, aggressive writing in schooling, that should be avoided because that can lead to the further erosions of these ribs, especially the posterior ends. Look at this subluxation of the joint spaces over there, and MCP stands for the metacarpophalangeal joints, and ankylosis. A stage comes when all these 8 bones of the carpus you can't appreciate. I'll show you one of the exercise slides over here. Here you can appreciate the joint space, but look at this. All the joint space, these bones, 8 bones which are over there, carpal bones, they completely becomes decrease in density. The joint space is totally finished, almost narrow, and there are multiple erosions, and the movements are very much restricted over there. That's in the advanced stages. But sometimes you can appreciate even these subluxations and bony deformities over there. Again, you can appreciate marginal erosions over there. They are going inside. Look at the soft tissue swelling. The diagnostic soft tissue swelling between rheumatoid arthritis and gout is fusiform, symmetrical on either side. If this is joint is involved, if this is joint, यहाँ से भी fusiform होगा, यहाँ से भी fusiform होगा, but in gout only one side. That is very much diagnostic sign. Now coming to the gout, look at this lower extremity. It's known, and we all know by our old books, it's a disease of king of diseases because of the high protein diet, varieties of food. They are more prone. But the diagnostic sign, if you ask between, sometimes you find the patient with a subtle signs difference between two. The best is go for the history. The rheumatoid arthritis is going to involve this joint first of all, but in gout, it's the big toe is going to be involved. Number 2, the serum uric acid is going to be high in gout disease, well, not in cases of rheumatoid arthritis. And finally, once you do the biopsy, you can appreciate the tophi as a calcific spots in the soft tissues, which has cases of gout and not in cases of rheumatoid arthritis. But the lower extremity, upper extremity, small joint, that's the way it gradually spreads from it. First of all here and then gradually. First metatarsophalangeal joint is the most common site, big toe, as I told you earlier. Marginal paraarticular, that is diagnostic sign. In rheumatoid arthritis, it is subarticular, just above the opposite bones, like this. But in gout, this is area, periarticular, where this synovial membrane is finishing, then the erosion starts. But in cases of rheumatoid arthritis, you can find these erosions in the articular space. Erosions may have sclerotic margins because of the response. Joint space may be preserved but may be narrowed. Soft tissue and bursa deposition, that is very, very important. Tophi or juxta-articular helix of ear, sometimes you can find it here. There is a calcification, you can appreciate, there's a diagrammatic presentation in the adjacent to the soft tissues. There you can appreciate that. Look at this bone. Please, history is very important. Sometimes diabetic foot may present like this, but again that's going to involve these phalanges, the most terminal phalanx. If you look at this bone over there, there's irregular, there's soft tissue calcifications, soft tissue mass as well, and soft tissue edema. This is known as eccentric swelling, where in rheumatoid arthritis there is fusiform swelling. One side is swollen, other side is absolutely normal. That is a diagnostic sign. Soft tissue calcified tophi you can appreciate over here, and irregular margins of the bone disease damaging. Serum uric acid is high, which is a diagnostic. Again, erosions you can appreciate. They are not bilateral. Look at this side is normal, this side is swollen, this side is swollen, this side is normal. So these soft tissue swellings are eccentric and not symmetrical bilateral. Word about metabolic disease like osteopenia, that means either the bone quality is decreased or the bone quantity is decreased, but the bones are there. I'll just go through it. I'll just show you one more slide. That's very important because time is getting short. I'll just rickets. Please let me tell you, once you find a small baby in your practice, the first action the baby starts after delivery is 4 months, and the first presentation is जब baby चलना शुरू करता है, वो करता है, crawl करना शुरू करता है. The first positive finding in cases of rickets will be once the mother brings you to the baby, please see these wrist joints. you will find some knobs here, soft tissue swellings over here. That is the earliest clinical sign presentation of a patient with suspicion of rickets over there, because the first action of the baby after the birth lying down is crawling. तो जब से पहले चलेगा तो हाथों पे बोझ डालेगा, जो ही हाथों पे बोझ डालेगा, if this baby is a case of rickets, the first thing is knobs on the wrist joints, soft tissue swelling, तो ज़रूर इसको examine कर ले if you are suspecting this rickets ना भी हो. Second thing is, once you are doing for the X-ray of the chest, very important sign is in newborn or in small children, X-ray chest does not mean only lungs and the heart. Please, X-ray chest means the entire area in that skeleton, and the X-ray chest means upper end of the humerus. X-ray chest means the diaphragm. So once you're looking for the X-ray chest, please look for this upper end of the humeri, because that is the other area where you'll find these typical classical signs of rickets, which I'll show you in this next X-ray. So X-ray chest is more than enough for all kinds of informations, but the first thing is to look for these hands. Second thing is, when the baby starts moving, start running around, then look for the upper end of tibia, lower end of tibia, but that is a later presentation. The first presentation is knobby or bumpy of these wrist joints. And if you go look at wrist joints, soft tissue swelling, some bit here, but look at the X-ray, there is basically metaphyseal disease, and there is absence of calcifications because of the deficiency of the calcium or vitamin D deficiency. The classical sign, three signs are: number one, there is lucency in the area of metaphysis; number two, there is widening of the ends; number three, there is splaying of the ends, and there is deepening of this. If you look at this, normally it should be one smooth end like this, as I will show you one of the X-rays. If you look at this, yes, this is. If you look at this lower end of the radius in the ulna, they're very gentle, very smooth, and you can find this epiphysis and the metaphysis over there. But if you look at this baby, look at this X-ray. There is widening, there is splaying, there is fraying of the distance, and there is loss of bone density at the metaphyseal ends. That is a diagnostic classical sign. Sometimes you will find this kind of X-ray, this kind of X-ray. That means if the patient has come to you for the first time and do the X-ray like this, ask the patient क्या इसने treatment लिया हुआ है, because if the lady has taken some treatment but is a haphazard treatment, the first thing, because of the deposition of calcium back over area, you will find these vertical and horizontal at right angle dense lines. That means the patient has taken somewhere some treatment which may not be complete, and you can find these dense lines. Dense lines means किसी न किसी तरीके से patient ने थोड़ा बहुत treatment लिया, because of economics, because of change of doctor, because of any reasons, or because of negligence, she discontinued treatment. But you find these dense lines over there, that means the patient is a known case of rickets, and she has given the treatment to the child but not the complete diagnosis. The other signs which you look for is costochondral junction. If you look at these anterior ends of the ribs, these are the posterior ribs. The posterior ribs always are in close proximity to the spines. That is diagnostic sign. They go downwards and outwards. The anterior ribs, they go forwards and medially. Number two, the anterior ends, they never reach this midline because of the cartilage structure. This junction between the anterior ends of the ribs and the sternum is cartilage, and the cartilage is radiolucent, so the hair is just passed down. But the diagnostic sign in rickets in the babies is, if you find this junction, costochondral junction, they are wide and they are swollen. If you look at this again, you can appreciate here, you can appreciate here, you can appreciate here. These are the widening of the distance. Other areas which you can look for is lower end of the upper end of the this knee joint, you can appreciate here. Lower end of the femur, you can appreciate here. There's decrease in the bone density, there's widening of the metaphysis and splaying of area, or there's the area where the patient has taken some treatment. Sometimes you can find the adult rickets after the age of 7 or 8 years, and these are deformities those patients are going to have it. Look at the bowing of it, look at the bone density, the loosened lines over there, indicative of rickets. This is known as juvenile rickets, and you can find the fracture. And the girls, especially when they have it, they got the waddling gait over there, they can't walk straight. You need the joint, they always lock the knee joints. Osteomalacia deficiency, but in the adult age, mature skeleton. And the diagnostic and the beauty of this osteomalacia is there are certain characteristics area which you can look for, and they are always bilateral. And the predominant area which you can look for is either at the pubic symphysis, looser zone, we call that the loosened lines. They are not the true fracture, they are looser zones. Or number two, they may be medial ends of the upper end of the humerus, medial end of the upper end of the femora. These are the areas which you can appreciate, or at the level of the sternum. I'll just show you here sometimes. Look at these loosened lines. Look at these loosened lines, avoiding. That's diagnostic of osteomalacia. But other thing is generalized decreased bone density. osteoporosis or osteopenia you can find in these patients, in addition to loosen zones. Acromegaly, sometimes you can appreciate these patients who are going beyond their physique and they look bigger. There are certain 4 areas, please look for all those areas. Number 1, hands. Number 2, feet. Number 3, skull. Number 4, spine. And 1 or 2 finding in each area you must look for hands. How they look like? Spade-shaped tufts due to the overall enlargement. I'll just show that these